for today is the approach to blistering disorders. So our speaker today will be Dr. Yong Shin Shen, and our chairperson will be Dr. Pubalan Munyandi. So just a brief introduction. Dr. Pubalan graduated from UM in 1987, obtained his membership in 1992. He further trained in genitourinary medicine in the Society of the Apothecaries, London in 94. Subsequently, attained his fellowship in 2018, and currently he is the head of department and senior consultant dermatologist in Sarawak General Hospital, as well as adjunct professor of medicine in University Malaysia, Sarawak. Without further ado, let us welcome Dr. Pubalan.
Okay, first, you can hear me, huh?
Yep.
Okay, first and foremost, thank you for inviting me to chair this session this afternoon. Just to update you, I've just retired from Sarawak General Hospital. I'm now on my own. It is actually a great pleasure to be chairing this session for Dr. Sean Yong, who will be speaking on approach to blistering disorders. Dr. Yong graduated from the University Kebangsaan Malaysia in 2020, attained his MRCP in 2014, and then graduated from the Advanced Masters of Dermatology in UKM, right, in 2020, if I'm not mistaken. And he's at the moment the head of dermatology at the University of Malaya Medical Center, and he's very actively involved in internal medicine duties, undergraduate medical students and teaching. His career clinical interests are in pigmentary skin disorders, acne, and severe inflammatory skin disorders, particularly in psoriasis, atopic dermatitis, skin graft versus host disease, and a variety of others. This afternoon, he's going to take us through the topic of blistering disorders. Blistering disorders are a big topic in dermatology, and it has got a lot of implications in the management of patients, especially in autoimmune blistering conditions. And it is appropriate that he updates us on one of the common things that we see in dermatology, which are blistering disorders, notably pemphigoid and pemphigus. Without further ado, I would call upon Dr. Yong to update us on the approach to the management of blistering conditions.
Yeah. Thank you, Dr. Pubalan, for the very kind introduction. Yeah, and yeah, I'm very honored to be invited here to have a quick talk on our blistering skin condition. And sorry, I just need to share my screen first. And just give me a second. I just need to make a tiny correction that actually I'm not the I'm not the head of unit for dermatology. It's Dr. Guan now. It's okay. Yeah. So one moment, just give me a second. I understand that today most of the audience are from they are mostly physicians and also medical officers, and I'm very happy to sort of share this. Sorry, one moment. I'm very happy to sort of share my presentation on this blistering skin conditions. All right. So I just want to. Sorry, I think I made a mistake. Sorry. All right. Can you all see my slide now? Okay, so a blistering skin condition is a very common condition when we among dermatology patients, and we do have a lot of patients come to our clinic because of blisters or vesicles, and many times that we receive many referrals, and I would like to share with you on what are the common blistering skin diseases and how do we approach them. So when we talk about blister, it's a blistering disease is a condition where there's a fluid-filled skin lesions. Usually when we talk about vesicles, they are very small blisters, less than 5 mm in diameter, where a blister or bullae in plural, they are a larger blister. They may break or the roof of the blister may become detached and form an erosion sometimes. So the exudation of the serous fluid will form some crust after it breaks. So here's a picture of a different type of blisters. As you can appreciate from the left side, this very tense, shiny kind of blister, okay, it means that this blister is very tense, all right? This is what you describe as a tense blister. The picture on the right, you can see that there are some fluid-filled, there's a fluid-filled blister, but the roof of the blister is rather flaccid. So we call it a flaccid blister. Before we go into further on how do we differentiate the blisters, or how do we classify blisters, I would just like to bring you through the very normal histological structure of skin. All right. In the epidermis, all right, there are about 4 layers. We have the stratum corneum, which is the very superficial one. It's where the dead keratinocytes to desquamate from time to time. The second layer is a granular layer. The third layer of the epidermis is the spinous layer, and the fourth layer of the dermis is of the epidermis is called the basal layer. What can go wrong here is that, you know, if in different diseases, all right, and then like if let's say the pathology of the disease is targeted towards the in between of the epidermis, the keratinocytes, okay, you might form an intraepidermal blister. And let's say if there's if the disease is targeting the layer at the basal layer, basal keratinocyte there, you might form a subepidermal blister. And look at the picture over label A here. You can see that in our skin, there are many skin cells or keratinocytes. All the skin cells, they are actually being attached or being held together by desmosomes, which is kind of a protein that makes sure that our skin cells, they are held tightly together so that they don't break away. So if there are diseases targeting the desmosomes or the heavy desmosomes, you might have a different kind of blister. And so there are many causes of blistering skin conditions. When you talk about blistering skin conditions, we sometimes would like to differentiate them into whether they are immunobullous disease or they are non-immunobullous disease. And if they are
sorry, Dr. Yang, can you use
the
slideshow, because we cannot see the full
Oh,
slide.
is it? Okay, sorry. Let me stop sharing again. Sorry for the technical glitch. Huh? Is it better now? Sorry.
Yes, thanks.
Yeah. All right. So we talk about causes of blistering skin diseases, right? Okay. We like to differentiate them into whether they belong to immunobullous diseases or they are non-immunobullous diseases. In immunobullous diseases, again, depends on the level of the blister formation. If it forms within the epidermis, all right, and then they can be, for example, Pemphigus vulgaris, Pemphigus foliaceus, or less commonly is our AGA pemphigus or paraneoplastic pemphigus. If the blister forms below the basal keratinocyte, all right, it can form bullous pemphigoid or mucous membrane pemphigoid or linear IgA disease. Many other things can also cause blistering skin conditions due to non-immunological causes. For example, infection, viral infection such as varicella zoster, bacterial infection like Bullous impetigo or fungal infection, they can cause blister as well. Certain medications that can induce photosensitivity can also form a blister. And like, of course, immunological problems such as toxic epidermal necrolysis or SJS, they can also form a blister. And like certain other rarer conditions, for example, Sweet syndrome or mastocytosis, they can present as blister as well. So again, depends on where the pathology is. A lot of if the pathology is targeting, if the autoantigen is targeting the intraepidermal layer, you might have things like a Pemphigus vulgaris, where the blister is formed at the intraepidermal layer. And if the blister is at the basal keratinocyte layer and below, it may form a subepidermal blister. So how do we approach autoimmune skin conditions? When we see a patient with blister in the ward or, for example, in the clinic, a lot of times, very importantly, we still need to take a very clear clinical history or physical examination. We need to ask about their age, all right? And then like, do they belong to, are they taking any special medications? Or like, do they have any pre-existing comorbids, for example, stroke, dementia, all right? And then very frequently, after that, we will perform a skin biopsy. Okay, we will cut out the blister, and then like under the microscope, we can determine which level of blistering it is. And also we can do some direct immunofluorescence, all right, to look for what are the tissues, bound antibodies, and also sometimes we can do indirect immunofluorescence, look at the serum autoantibodies. Then eventually we can actually reach a diagnosis. So, for example, this is a normal skin here, all right, and then like if the disease is targeting the depends on which level of disease is targeting, and like it can form different kind of blistering problems. This is a structure of a basal basement membrane structure, and like it just look at this very tiny layer here. Within this very tiny layer of basement membrane, inside there, under the electron microscope, there are multiple proteins being involved, and they can actually cause different kind of blistering disorders. I'll explain about it later. All right, and like let's put this slide later on. For example, this is just trying to tell you that like in this whole picture, all right, there are actually so many things can happen. Different kind of diseases with different kind of antigen that's being targeted, and like what will the direct immunofluorescence pattern look like if they are under the microscope? Okay. So I'm going to do a case one, yeah? So so this is a 70-year-old female. She has Parkinson's disease for the past 10 years, and she also has diabetes and hypertension, all right? She presented with itchiness over the trunk and limbs for the past 3 months. Then after that, the family members noted that there are many blisters over the legs and the trunk for the past 2 weeks. So she came to our clinic, and then like we look at it. So what is the next step? Next step, generally, we will try to biopsy the blister to determine the, like what is the underlying problem, all right? And then so when we try to biopsy the blister, a dermatologist or we will try to cut around the skin of the blister, okay? Trying our best to preserve the blister, and then so that it doesn't break, and then send the whole blister in the formalin for examination. And direct immunofluorescence can also be very helpful to look at like what kind of immunofluorescence pattern it is, okay, for this blistering disorder. When we cut it out, okay, and then like at the side of the blister here, the normal skin, we will take off a piece of the normal skin besides the blister to send for direct immunofluorescence. I'll explain what direct immunofluorescence is later. So in this disease, sometimes you can see that, like, you know, this particular problem is called Bullous pemphigoid. So Bullous pemphigoid is a autoimmune blistering skin conditions where the autoantigen is being directed to our keratinocyte hemidesmosome protein, which is the BPAG1 and BPAG2. It usually happens in elderly patients. All right. Before the blister happens, a lot of times, sometimes they can present to us with, like, for example, they will complain like, oh, they have very itchy plaques over the body, and then like some of the plaques may look very urticated, and then some will look very urticated papules. All right. And then, for example, just like this picture, all right, you don't see much blister here, but this could be one of the presentation of the Bullous pemphigoid, which is they have this kind of urticated plaques. So the blister can be small or can be large, but usually it's very tense, all right? And then like the top is actually quite firm and it can be oval or round. The contents of the blister can be serous or hemorrhagic. And then like sometimes after the blister eroded, and then like it will form erosions. It usually distributed over the lower legs or the medial aspect of the thighs or the groin, abdomen, can be over axilla, but very rarely, it can be at the mucous membranes. But usually it will not be at the mucous membrane. All right. Initially, patients will always come to us, they'll complain of very severe pruritus, very itchy. Later, you know, they will the blister will break and then they will leave on an erosion. All right. And then after that, some of the when the blister roof collapse already, after it dries up, it can become a crust. Okay. So we will send the skin biopsy to, we will send the blister skin biopsy for histopathological examination. Under the microscope, you know, you can see that, like, you know, this is what I meant just now, that like there's a split at the subepidermal level, which is where my cursor are now. And so this is a blister cavity. Inside the blister cavity, you can actually see that, like, sometimes there will be some eosinophils or neutrophils inside there. And then like this is a very nice structure of the blister being cut out, you see under the microscope. And if you can do a direct immunofluorescence, by right, you will see that, like, you know, there will be a linear band of this fluorescent light shining up, okay, on our immunofluorescence. This linear band of fluorescence light is due to the linear IgG and C3 being light up, okay, at the basement membrane zone. This is very characteristic of our Bullous pemphigoid. If we do some blood tests, at most, usually we can detect maybe a little bit of eosinophilia, Okay, so what is direct immunofluorescence and what is indirect immunofluorescence? A direct immunofluorescence is whereby that we try to detect the autoantibodies or the complement deposits. Okay, usually we need to detect it at the perilesional skin, which is what I explained just now. For example, if we cut off this blister and then we will try to take out the piece of skin adjacent to the blister, we will send this piece of skin to immunofluorescence. And under immunofluorescence, you can see this kind of picture, okay, if it is a bullous pemphigoid. All right. It's a very useful way to complement our diagnosis of an autoimmune skin disorder, blistering disorder. How it's done is that like we take a solution that contains the anti-sera against the IgG, IgA, or IgM, okay, that can be conjugated to the fluorescence dye, and then we incubated it, and then we look into the fluorescent epifluorescent microscope, and then we can see the relevant antibodies being lightened up. For indirect immunofluorescence, usually it's a serologic test. We will test the circulating antibodies in our body, and then it can be done by the antibodies in the patient's serum, all right? And then you culture it on some non-patient's epithelial specimens, such as monkey esophagus. You can see whether it is a bullous pemphigoid or any other type of autoimmune problems or not. So we recently have an update on like how do we treat the patients with bullous pemphigoid. All right, bullous pemphigoid, it also depends on the therapeutic ladder. All right, depends on whether it's a mild bullous pemphigoid or severe bullous pemphigoid. For mild bullous pemphigoid, a lot of times we like to start with some topical corticosteroids. Okay, we apply on the early urticated papules, okay, or the plaques, all right, before they turns into a blister. And let's say if they are blisters formation or like it's not very localized, but you can see quite a number of blisters around here and there over the body, besides the topical corticosteroid, okay, and then you might need to start on oral corticosteroids already. Usually we will try to aim the oral corticosteroids at about 0.5 milligram per kilo, all right? And then like some of the dermatologists will also like to add on doxycycline or dapsone, all right, to try to control the blister, okay? Because doxycycline or tetracycline, it has a basement membrane stabilization effect, okay? It can also, it can show like help with reducing the number of blisters. If let's say a patient has a very severe bullous pemphigoid, okay, the first choice being, of course, super potent topical corticosteroid can still be helpful over those areas with some urticated plaques, okay? But we will try to maybe increase the dose of prednisolone up to 0.75 milligram per kilo. And sometimes we might actually need to add on some conventional immunosuppressive drugs as a steroid-sparing agent, such as methotrexate, azathioprine, or mycophenolate mofetil, if it is a corticosteroid-dependent or relapsing bullous pemphigoid. All right. There are newer drugs that can be used for bullous pemphigoid, but which is not very commonly done yet. All right. In our country, I will say, for example, you can use Rituximab, which is an anti-CD20 monoclonal antibody. All right, to deplete the B cells. All right. And recent studies also support the use of omalizumab or dupilumab, or to some extent intravenous immunoglobulins to treat a very severe and also treatment-recalcitrant bullous pemphigoid. All right. Lately, we have a lot of advances in our diabetes treatment. For example, we have this kind of linagliptins or sitagliptins, which is a DPP4 inhibitors. All right. These DPP4 inhibitors is found to be associated with, to a certain extent, the production or the occurrence of bullous pemphigoid. So it's very important sometimes to assess our patients' drug history, to ask that, prior to the onset of bullous pemphigoid for the past few months, okay, have they been started on any new diabetes medication? Because as we know, most of our diabetes patients, they belong, our bullous pemphigoid patients, they belong to an older generation, and they will have a lot of comorbidities, for example, diabetes, high blood pressure. And DPP4 inhibitors are found to be associated with to the occurrence of bullous pemphigoid in a small number of patients. And then like recently also we have a lot of checkpoint inhibitors which is used in melanoma or solid organ cancer treatment. Patients on this kind of medications, they are also prone to develop bullous pemphigoid, okay, because this kind of drugs have this kind of anti-BP180 IgG effect. And we also wonder why that bullous pemphigoid is more common among patients with neurological disease, okay, especially those with stroke, Parkinson's disease, or multiple system atrophy. If we see in a clinic, they usually have dementia, you know. This is just a postulation. Maybe that there's some alterations in the CNS in the cause of pathological changes in those patients with neurological disorder, because there are some sort of neural isoforms of BPAG1 or other BP antigens that can be produced. And then autoantibodies, again, these antigens in the brain, they can actually cross-react with the antigen in the skin, which will actually cause the development of bullous pemphigoid. So I've presented the case of bullous pemphigoid. Now I'd like to move on to another type of blistering condition. For example, this is a 40-year-old man. Okay, he's an engineer. He doesn't have any medical illness, married with a daughter, and then he presented with painful erosions in the mouth for the past 2 months. He went to see a few dentists, all right, and then he was given some craniocord paste, and then was treated as after ulceration, and then but the erosions and the ulcers didn't resolve. And then subsequently, he noted that there are some small flaccid blisters over the chest, all right, and then they would erode, and then it progressed into some very painful erosion. And so this is a classical presentation of Pemphigus vulgaris. Pemphigus vulgaris is an autoimmune blistering disorder. It's due to the loss of the cell-to-cell adhesion in the epidermis, all right? And it usually starts in the oral mucosa, the ulcers, or the flaccid blister. Less frequently, it can actually start as a very generalized acute eruption of blister as well. It's associated with severe pain, okay? Patients always complain of very burning and painful erosions. And then the erosions can also affect the mucous membrane, not only the mouth, it can actually go behind the throat, okay? Or inside the nose. It can actually cause epistaxis, hoarseness, and also dysphagia. Because of the pain, patient can't eat. Usually they will present to you to be really weak or loss of weight. And then it usually come out with a vesicle or bullae, usually a bullae, all right? Inside the bullae, there can be some serous contents, okay, or even there can be even some blood inside there. They are quite flaccid and easily ruptured, all right? You might be able to demonstrate a Nikolsky sign on patients with this kind of Pemphigus vulgaris, sorry, all right? What does it mean? It means just imagine that this is actually a flaccid blister before that, or it's just erosions, but the surrounding skin initially they seem quite all right, but if really just put some pressure lateral to it, on it, okay, this piece of skin can just slide away, all right. This is due to the dislodging of the normal appearing epidermis, all right. This is a positive Nikolsky sign, and it's very classic of our SJS-TEN or even the Pemphigus vulgaris. So it doesn't really have a very special pattern distribution, all right, such as our bullous pemphigoid. In bullous pemphigoid, the blisters can be usually over the hands and the legs region, all right, or over the trunk. But for Pemphigus vulgaris, the pattern distribution of the blister can be quite random, okay? It can be localized, it can be generalized, it's very serious, all right? But it does have a predilection for scalp, the face, the chest, or the axilla or groin area. And very importantly, it has a very significant mucous membrane erosions, especially over the mouth or the pharynx, okay? Sometimes can involve the genitalia as well. So how do we investigate for Pemphigus vulgaris? In Pemphigus vulgaris, again, when we see this flaccid blister, we will try our best to biopsy the whole flaccid blister out and also send the perilesional skin for direct immunofluorescence. And inside this, let me show you the picture. So this is a picture of the Pemphigus vulgaris histopathological slide. You can see that there's a blister formation that's inside the intraepidermal layer, and you can actually see that the other layer of keratinocytes are still lining down here, and then all of them sort of standing alone, and they don't really kind of being attached together, okay? That give you a very tombstone appearance, just like our tombstone, all right? And then, so this is the intraepidermal blister, and then with acantholysis in between of the cells. And then if you do a direct immunofluorescence, which is you culture the cell and then put under the fluorescence microscope, you can see a net-like IgG deposition predominantly within the lower epidermis. All right. So, for example, this is where it goes wrong. Okay. Just now when we talk about bullous pemphigoid, what really goes wrong here is at this level. And then when we talk about pemphigus vulgaris, what really goes wrong here is at this level. So classically, besides the intraepidermal blister, they have acantholysis or acantholytic cells. Acantholysis in pathology term, it means loss of cell-to-cell adhesion. All right. For example, you see here, just imagine that all these keratinocytes, supposedly they should be actually conjoined properly and tightly, okay, in normal individual. But in patients with pemphigus, all right, and then like the things that conjoin them, the cement conjoin the protein or the cement, I would just like to use this analogy, that conjoin the two keratinocytes are being attacked by the autoantigens, all right? And the cement are usually the desmoglein 1 and 3 or desmocholine, all right? So it's being attacked, then they lost connection, so they break off, and then so you can see all the cells are actually very acantholytic, which is loss of cell-to-cell adhesion. All right. So this is a very painful condition. How do we manage patients with pemphigus vulgaris? All right. Besides starting all the medical treatment, a lot of times we need to address a lot of other issues. For example, pain management. All right. We need to dress the wound. Okay. Wash the wound properly with normal cell lines, and then like prevent the superficial skin infection with antibiotic. Okay. And according to this latest guideline of the management of Pemphigus vulgaris and Pemphigus foliaceus, okay, according to the European Academy of Dermatology and Venereology, nowadays even mild or moderate or severe Pemphigus, they suggest that to use the Rituximab, okay, as a first-line treatment. But however, I will talk about Rituximab later. In our practice, okay, it still depends pretty much on systemic corticosteroids, okay, as a first-line treatment. For example, if somebody comes in here with a few flaccid blisters, painful oral erosions, we usually start them on oral prednisolone first, like 45 to 1 milligram per kilo per day. Bear in mind that in this group of patients, because the inflammation is more serious, okay, you may actually end up needing a higher dose of steroids or prednisolone compared to patients having bullous pemphigoid, okay? And then like, so after you start steroid, you also need to add on steroid-sparing agents, for example, azathioprine or mycophenolate mofetil, all right? And then like, because this kind of inflammation will naturally need a longer period of immune suppression to achieve a remission, okay? And if the disease control is achieved, all right, you can continue with the treatment, and then like you will slowly decrease the oral steroid to prevent further side effects such as glucocorticoid dependent side effects, okay, over 3 to 4 months. All right. Let's say if this patient the disease is not being controllable, okay, you might need to consider whether to add on rituximab or not. Okay. And again, when you deal with a moderate to severe pemphigus vulgaris or pemphigus foliaceus, for example, more than 50% of the body surface area, they are full with this kind of pemphigus, all right. Again, the guideline also suggests the use of rituximab infusion, all right, or start with systemic corticosteroid first, okay, and then like and the systemic corticosteroid in moderate to severe pemphigus vulgaris or foliaceus, it has to increase by up to 1 to 2.5 milligram per kilo per day in conjunction with other steroid-sparing agents, for example, mycophenolate mofetil or azathioprine, all right? And like, let's say if, again, you look for 3 to 4 weeks later, see whether there's any improvement or not, all right? And then like, for example, the group of patients that we usually deal with in our local setting, they will be initially treated with systemic prednisolone, all right? If this doesn't work, okay, you may consider add-on rituximab or add-on immunosuppressant, for example, azathioprine or mycophenolate mofetil. All right. The reason that I think the most important reason that we are not using rituximab so frequently, all right, in our setting is because number one, the cost. Rituximab, one course of it will actually generally cost about 20,000 ringgit. And like at the same time, there are also a lot of very significant immunosuppressive side effects. And then the use of rituximab has been a little bit disrupted, okay, over the past 2 years because of the COVID pandemic. All right. And then let's say if a patient is very fortunate, okay, to be started on rituximab first, all right, during the first onset of the disease, okay, and then you may also, while waiting for the rituximab to take action, you may also need to start the patient on systemic corticosteroid first, all right, and slowly taper off while waiting for the rituximab effect to take place. Okay, so this is case number 3, and this is a 35-year-old man, and then he has a progressively increasing number of flaccid blisters over the trunk and the limbs, okay? And all these blisters will become an erosion, which is very painful. However, unlike the second case, the previous case, he doesn't have any oral ulcers or oral erosions. All right. You can see that, there are multiple flaccid blisters that dry up or become big crust like this, just sort of distributed on the trunk and also over the legs as well. And you can see the erosions over the legs there is just about to heal up and then still a bit fresh, so a bit erythematous. All right. And you do a skin biopsy of this patient, all right? And then again, you will see an intraepidermal to subcorneal kind of blisters here, all right? Where the blister level is slightly higher than the previous intraepidermal blister that we see in Pemphigus vulgaris. This is also another form of Pemphigus, which is Pemphigus foliaceus, all right? The direct immunofluorescence also shows some net-like deposition of the IgG within the epidermis. Okay. The management of mild Pemphigus foliaceus will pretty much the same as mild Pemphigus vulgaris, okay? Except that, we usually use some topical corticosteroids or systemic corticosteroid first. And then if in a suitable cases, you may even consider rituximab, even though it's a mild Pemphigus foliaceus. And then if let's say you didn't use any systemic corticosteroids or steroid-sparing agent in the first place, and if the disease progress and is not under remission, you may consider rituximab or further increase the systemic corticosteroids and add on mycophenolate mofetil as a steroid-sparing agent later on. All right. And of course, later on, we always need to check for disease control later. Okay. So, why is that certain areas, certain times like Pemphigus vulgaris, you have a lot of oral erosions, but Pemphigus foliaceus, you don't have much oral erosions or mucous membrane erosion. All right, this very special phenomenon, okay, can help us to differentiate if this patient has flaccid blisters, very painful, whether it is a Pemphigus foliaceus or Pemphigus vulgaris. We can roughly see from the mucous membrane. For example, this in our skin, okay, there will be a lot of desmoglein 1 holding up the keratinocytes, and then while desmoglein 3 are not so many. In the mucous membrane, there are more desmoglein 3, all right, and then holding up the basement keratinocytes, but less of desmoglein 1 holding up the keratinocytes. So I always remember this way: Pemphigus foliaceus, F comes before V, okay? In Pemphigus foliaceus, the disease is usually targeted towards desmoglein 1, all right? So in Pemphigus foliaceus, if the autoantibodies is targeting the desmoglein 1, it sort of inhibits or it sort of impact all the desmoglein 1 function, all right? So the skin will break down, but you don't have much desmoglein 3 to hold up the skin, all right? And then so Pemphigus foliaceus patient, they will present with a lot of skin problem. But Pemphigus vulgaris, usually the autoantigens is directed towards the desmoglein 3, all right? So in your mucous membrane, you have a lot of desmoglein 3, but you don't have a lot of desmoglein 1. So the desmoglein 3 will be targeted, and then there will be breakage of the mucous membrane and the keratinocytes in the mucous membrane, and then they will always form some oral ulcers and erosion. So the use of rituximab in the Pemphigus treatment has been a very exciting thing, and then we have been using it, more and more frequently, and then especially over the past few years. It might be not very new, okay, in the European countries or even in US, all right, and then but it's sort of only being recently approved by the US FDA in 2018, okay, for the frontline treatment of moderate to severe Pemphigus vulgaris and Pemphigus foliaceus, all right. Rituximab is actually an anti-CD20 monoclonal antibody, which targeting the B cells. All right. The reason that we use rituximab is because, like, there is a very deep disease memory, okay, in pemphigus, pemphigus vulgaris or pemphigus foliaceus. By using the conventional immunosuppression like oral steroids, okay, together with mycophenolate mofetil, it can suppress the disease activity, but it cannot, in half the cases, it cannot be suppressed fully. Okay, patient will still be suffering from the blisters and the erosions. To achieve a much better control, we might actually need something that can produce a more profound immune suppression, which is to deplete the CD20 expressing B cells that is involved in the disease memory, so that there will not be more autoantigens being produced in the future to cause blisters. Rituximab can be administered in two ways, all right? One is a lymphoma dose regime, one is a rheumatoid arthritis dose regime. Our rheumatologist colleague, they have been using rituximab very frequently, and they're very familiar with using it. And their dose of using it is by using a 1,000 milligrams or 1 gram infusions, okay, every 2 weeks apart, all right? For lymphoma dose regime, all right, which is used by the hematologist, and they usually do it by calculating the body surface area. Okay, they are giving it 375 milligrams per meter square weekly. Okay, for 4 weeks. So previously we actually have this rituximab. We have quite a number of studies and then our randomized trial, okay, to look at the efficacy of rituximab, which dose is more superior, whether the rheumatoid arthritis dose or the lymphoma dose is more superior. And recently there's a study published to look at the factors associated with a complete remission after rituximab therapy for pemphigus. Okay, and then but before I go in further, okay, I would just like to say that there are certain factors, okay, that will determine whether or not even after rituximab the patient will relapse or not. All right. For example, they find out that those patients who use a rheumatoid arthritis dosing regime, okay, they might have a higher risk of relapse after using rituximab, despite that rituximab is so effective. Okay, this is because lymphoma regime, all right, it's being calculated adapted to the patient's weight. So theoretically, it will produce a much accurate effect and then a much sufficient dose, okay, to suppress the patient's, to deplete the patient's B cells. And decreasing age means those who are younger, all right, they might also have a more relapse after using rituximab compared to the older patients. This can be possibly explained by the way that it could be due to stronger immunity in the younger people compared to the older people. And of course, those who are obese or BMI greater or equal to 35, okay, they will also be associated with a higher risk of relapse after rituximab treatment. All right, and then because rituximab, because with a higher body weight, perhaps the dose might not be too sufficient or not too accurate. And of course, those with a very severe disease starting at the baseline, all right, and then or those who have this persistence of a serum anti-desmoglein antibodies at 3 months later, they usually will have more, they will suffer more relapse compared to those without, okay, after rituximab. The important thing about rituximab in this current endemic climate is that, it is associated with increased risk of severe COVID infection. All right, okay. And then certain studies that look at a cohort of patients, and then they found out that who received rituximab during this pandemic period, all right, they found that the incidence ratio of COVID-19 in patients treated with rituximab is almost 5.37 relative to those patients who did not receive rituximab, all right. And patients with AIBD who got infected by the COVID, if they received rituximab in the past, they might have a much higher 3 months death risk compared to those with AIBD without COVID, all right. So this really will sort of this will really make us think twice about how are we going to position ourselves when we want to treat our patients, with Pemphigus vulgaris or Pemphigus foliaceus Rituximab. The guideline says yes, first line, it can be used as first line, but perhaps we need to reconsider whether during this period of time, shall we actually hold back to it first, and then perhaps start other treatment rather than Rituximab, okay? Despite that it's a very effective treatment. All right, so blisters are not always also due to autoimmunity. All right, I'm just going to present another case, but I think maybe this case was presented. This scenario has been presented by the previous speaker. Again, I just want to make our audience aware that not all blisters are associated with autoimmune disease. For example, this is a 58-year-old female. She has diabetes and gout, all right? And then she presented with fever, painful red eyes, and sore throat for the past 5 days, all right? Then she started to develop a lot of blisters, some blisters and oral ulcers 1 day ago. And then when she came to the hospital, you can see some body surface skin detachment. It was difficult for her to eat and swallow. And then further history, you know that she was started on allopurinol. All right. So this is a classic picture of toxic epidermal necrolysis. You can see that the epidermis are necrotic. All right. They died off and they dislodge. All right. And they can sometimes present a blister first. They are blisters as well. Okay. If one might confuse it with Pemphigus vulgaris because they do have blisters, flaccid blisters, they do have erosions, and they do also have a fever or very painful erosion in the mucous membrane involvement. So that's why I say that history is very important. So yeah, I mean, this is toxic epidermal necrolysis, and then usually they present with fever, and they will have significant mucosal involvement, and drugs are majority of cases are due to drugs. Okay. And we need to know how to classify Stevens-Johnson syndrome or toxic epidermal necrolysis. In Stevens-Johnson syndrome, there will be less than 10% of the epidermal detachment. If let's say it's 10 to 30%, we call them SJS stroke TEN, and then if TEN is more than 30% detachment. All right. Drugs are usually the etiology. So taking a proper drug history is very important. All right. For example, those who are on allopurinol, anti-epileptics, they have a higher chance. Okay. Very rarely it can cause by mycoplasma pneumonia or some viral infections or even due to immunization. All right. The pathogenesis of SJS-TEN is manifold. Okay. Some say it can be due to the cytotoxic immune reactions. Okay. That is being produced to destroy the keratinocytes, all right, that leads to apoptosis and epidermal injury. And then they can also be due to drug-specific activation of the T cells, and then that cause all these cytokine storms, and then subsequently leading to local cell death, fever, and a lot of other systemic symptoms, all right. And again, if you take a skin biopsy of this blister, you might, if it depends on the biopsy method, you might already miss the blister roof, all right? But definitely the more striking picture will be a lot of necrosis out of proportion to the lymphocytes or full thickness necrosis of the keratinocytes. So is it always autoimmune or immunological? When we talk about blister, is it always that, gloomy? Is it always that dangerous? Well, I mean, most of the times it's really worth investigating, okay, because they can have a lot of serious implications, clinical implications. But certain things, for example, herpes zoster, bear in mind that they are usually present as a vesicles, okay, and then they're usually smaller, less than 5 mm, and I'm sure all of us, encounter herpes zoster from time to time among our patients. And as we know, herpes zoster is a localized blistering or vesiculation problem caused by reactivation of the varicella zoster virus. We like to describe this kind of rash by using this magical sentence. There will be crops of vesicles with erythematous space distributed along a dermatome, and it will usually cause severe pain or post-herpetic neuralgia. And treatment is usually by acyclovir, 800 milligrams 5 times a day, or we have to consider IV acyclovir or admission for patients who are immunocompromised. Okay. Another not so serious kind of blistering problems, okay, can happen in healthy people, which is like bullous impetigo, all right. It's usually due to Staphylococcus aureus infection. And then it's due to the production of the exfoliative toxins like the exfoliatins A and D that will target the adhesion molecules which is the desmogran 1 that present in the epidermal granular layer. So it will cause some dissociation of the epidermal cells and it cause some blister. Many times you will form this kind of honey crusted color lesions, around the blisters or erosions. And the treatment can be very simple with proper antiseptic wash and then oral antibiotics or even topical antibiotics, and then that patient will become better. And last but not least, even fungal infection, especially over the foot, can also cause some blister, which is what we call like a bullous tinea. All right, it's a foot infection due to dermatophyte fungus. All right, we have quite a big 3 major groups of dermatophytes, like our trichophyton, and then like epidermophyton, and also the tinea, trichophyton interdigital. This kind of thing can usually cause bullous tinea. All right. Perhaps the most important take-home message of this whole blistering skin conditions, all right, it will be how to differentiate Pemphigus vulgaris and Bullous pemphigoid. Okay. In summary, you will see that our Pemphigus vulgaris patients usually belong to a slightly younger age group, like around 40 to 60. While Bullous pemphigoid, they usually are the elderly age group, okay, 60 or usually 70 and above. They usually have a lot of comorbids. Some may actually present with, for example, neurological problems like dementia, Alzheimer's, all right? And then both also chronic and relapsing. That is why it is very important to biopsy the blister, all right, to confirm the diagnosis. Then only we subject the patients to a long-term treatment, all right, because all the treatments will be associated with significant side effects, all right. And for Pemphigus vulgaris, usually it's very painful, the erosions, especially inside the mucous membrane. For Bullous pemphigoid, usually they will have a lot of preceding urticated itchy plaques, all right? And then mucosal involvement, like the oral ulcer, this kind of thing is very common in vulgaris, Pemphigus, but it's not too common in Bullous pemphigoid. And the blister will always be more tense in the Bullous pemphigoid, but it's flaccid in the Pemphigus vulgaris. Nikolsky sign, which I said just now, you press on the lateral skin of the blister. If it slides away, usually it's positive in Pemphigus vulgaris, all right? And then for dermatologists, we always say that it's due to the autoantibodies directed against the desmogran 1 and 3 in Pemphigus, while in Bullous pemphigoid, it's due to the hemidesmosomal Bullous pemphigoid antigens being targeted, which is the BP230 and BP180, all right? Very importantly, in Bullous pemphigus vulgaris, usually there will be supravascular clefting or the intraepidermal blister, while for Bullous pemphigoid, usually you can see a subepidermal blister. So treatment-wise, both of them will need quite a bit of systemic glucocorticoids, okay, with non-steroidal or steroid-sparing agents, and the role of Rituximab. The role of Rituximab has been discussed, and it can be a very useful treatment, but perhaps during the COVID pandemic, we need to revise what we can do to make sure that our patients are in safe hands, okay, when we use Rituximab. All right, with that, I thank you.
Thank you, Sean, for the good overview of the blistering conditions that we deal with. Due to the limits of time, of course, you have to consider that, blistering diseases are a huge topic in dermatology, yes. But you have taken what is the essence that we need to look at and deal with the differential diagnosis of blistering diseases, notably between Bullous pemphigoid and Pemphigus, which is generally what is accepted, and to know that in the approach to blistering conditions, skin biopsies are essential, and immunofluorescence plays a crucial role in differentiating between one and another. So far, what about other differential diagnoses that you would have loved to talk about in these blistering conditions? If you have time.
If I have time. Well, we do actually see 1 or 2 interesting cases of pemphigoid gestationis. All right, and then that actually happens in pregnant ladies. I remember that when I was a physician, doing internal medicine, and then sometimes you need to, in the peripheral hospital, you will see pregnant ladies. All right, you don't just see old patients with diabetes, with heart attack, all these problems. And then pemphigoid gestationis, okay, will happen around the 2nd or 3rd trimester, or even the postpartum period of pregnant ladies. All right, okay. they will have the blisters that they will have itchy plaques over the body. Okay. Pregnant ladies, they do present to us with eczema sometimes, or polymorphic eruption of pregnancy. Okay, but sometimes when things started to progress into a blister, we better take it very seriously, and we better refer to a dermatologist or call out for help to biopsy it, okay? Because it has a very significant implications to the babies, all right? It can cause growth restriction and then or other postpartum complications. So they do need a very specialized care, because like they are pregnant, you need to be careful with the steroids, and you need to be careful with the systemic treatment. So I mean, like if you see pemphigoid gestationis and then like hence blisters in pregnant ladies, we need to pay extra attention to that, or refer appropriately. Yeah.
Okay.
Otherwise, yeah.
From the floor, if a patient has a prodrome of bullous pemphigoid, would you biopsy at the time without intact blister to confirm the diagnosis? If yes, where should we biopsy for the immunofluorescence, lesional or peri-lesional?
Yeah, that's a very good question, actually. In fact, a lot of times we are being referred to elderly with very itchy urticated plaques. Okay, sometimes we wonder, oh, is it an eczema, or is it a urticaria? And then like, so what I suggest is that yes, you can biopsy. All right, the direct immunofluorescence will always still be the peri-lesional, I think. And like for the biopsy, you might not be able to see the blister, okay, but you can see a very dense inflammatory infiltrates, especially eosinophil, this kind of thing. All right. And if let's say they don't have blisters, I think it's reasonable to treat with potent corticosteroids, and importantly to follow up. All right. Because if it is a bullous pemphigoid, eventually it will come out with a blister as well.
Yeah.
And then like when the blister comes up, talk to the patient. Can I biopsy you again? Because the implication might be longer, I need to give you more medications. Yeah.
So I think
it's still...
in this group of patients where you have early pemphigoid presenting as urticarial plaques, where you don't actually see blister, I think the best to do is a skin biopsy and IF from the lesion itself, or the edge of will be good, because that's where probably you'll demonstrate the thing. Whether to go peri-lesional outside the lesion, in the early stages, probably not so. But like I said, it's better to review the patient after some time and see how it progresses. That means, how does a lesion progress, whether it becomes blisters or not. Sometimes it takes months before it becomes a bullous pemphigoid actually. All right. So you may be treating it like an urticaria or urticarial vasculitis or something like that. All right. Yeah.
Yeah, I agree with you, because usually when the blister form already, and then it's quite hard to read the IF, from the lesion itself. So that's why you go peri-lesional. And then so it's very reasonable to take from the lesion itself for immunofluorescence in this kind of case. Yeah.
Now, the other thing that I want to bring out is, you see, one of the things that result in a blistering eruption is things like contact dermatitis, allergic contact dermatitis, which must not be forgotten, right?
Yes.
If you have seen plant dermatitis, they can cause severe blistering. In the UK, we talk about things like poison ivy. In this part of the world, we talk about something called rengas, a wood that we find in the forest here, which causes a very intense blistering. So in the approach to skin diseases with blisters, there will be to me, when I look at it, I look at acute blisters and chronic blisters. You understand what I'm saying? Whether they are very early in the presentation, or they keep on going for months to weeks to presenting at blisters. So we have to think about contact dermatitis as one of the causes of the blisters. Rarely you get blisters in atopic eczema, things like that.
Yeah.
Any other questions from the floor? I don't seem to have any other question. Anything else you'd like to bring up, Sean?
Yeah. Not really. Perhaps, if my message can sort of like show up here, and I'll just give my email address in case the audience in the future, they would like to ask anything, they can always email me. Okay.
I think since there are not many questions, I think I will just wrap up the session for today. I think the approach to blistering skin conditions, especially in chronic vesico-bullous eruptions, is mandatory that the same principles of a history, physical examination, investigations, and management be followed. In the important vesico-bullous condition that we consider in internal medicine would be pemphigus or pemphigoid, to differentiate between these two conditions. And you have taken us through this, and you have given us a broad overview of what we need to do. And bearing in mind, the diagnosis is very important in the management of the patient, because it's going to involve the use of steroids and immunosuppressant, including Rituximab. And Rituximab has actually changed the landscape of management of blistering condition, especially pemphigus. All right. With that, I'd like to thank Sean for his excellent presentation. I'd like to thank the Academy of Medicine for organizing this webinar, and I call this meeting to a close. Thank you very much.
All right. Thank you very much, Dr. Bhupalan. Thank you.
Are we done?
Yep. Thank you, Dr. Yong, for the talk, and thank you for sharing, Dr. Bhupalan. Thanks, everyone, for attending. Have a good day.